Onc Live Insights is a video editorial program produced by Onc Live.
There's emerging data that suggests that patients who relapse within 2 years of good initial therapy, say rituximab CHOP chemotherapy or rituximab bendamustine therapy, have a markedly inferior prognosis compared to patients who have not relapsed within that 2-year period. The difference is large. If you look at the probability of survival 5 years later, it's about 50-50 for those early relapsing patients, where it's well over 90% for the patients who haven't relapsed. So this early relapsing population is one that has really drawn our attention when this data became public within the last 18 months. It's definitely an unmet need to figure out, can we change the natural history for those patients who have really declared themselves as being in this high-risk category by virtue of their early remission after effective therapy. If it's a younger patient, those are the types of patients that I would recommend for consideration for stem cell transplantation. And if it's an older patient, that's a patient that I would think about an innovative strategy, a targeted therapy approach, a non-chemotherapy-based approach, because they just went through a chemotherapy-based approach. It did not get a great outcome from it, and so to go back to more chemotherapy is not very attractive in that setting. Idelalisib is a PI3 kinase inhibitor that's approved for use in recurrent follicular lymphoma for patients who have had 2 prior lines of therapy. It inhibits this enzyme called PI3 kinase, which appears to be an important kinase, important for B-cell survival. As I mentioned, this is an oral agent. It's a PI3 kinase inhibitor, a new class of drugs that has very good activity in B-cell malignancies, has good activity in chronic lymphocytic leukemia, follicular lymphoma, and it's a well-tolerated drug. Most patients have minimal side effects with this agent. A little bit of diarrhea can happen early on in the course. There is the risk for transaminitis, so that liver function tests have to be monitored very closely during the first, I'll say, 6 to 8 weeks of therapy. There is a risk for colitis that can happen later in course on therapy, inflammation of the colon. That more typically happens six or so months into therapy, and that can be a very serious side effect. And so if patients are observed to have that on idelalisib or any PI3 kinase inhibitor, the drug should be held, and appropriate therapy for the inflammation should be administered. Fortunately, that is a relatively infrequent occurrence. Fewer than 10% of patients have that. But the trial that led to idelalisib approval was in an unfavorable group of patients. These were patients that had so-called double-refractory follicular lymphoma, refractory to an alkylating agent and refractory to rituximab. Despite that poor population, the response rate was close to 60%. So it's a very active drug in follicular lymphoma. So if I have a patient with recurrent follicular lymphoma, particularly older patients for whom chemotherapy is not an attractive option, someone for maybe whom stem cell transplantation is off the table, I think idelalisib is a very attractive option for lots of patients with recurrent follicular lymphoma. The optimal duration of maintenance therapy in follicular lymphoma is generally considered to be 2 years. Most of the studies that have established maintenance as an attractive treatment strategy have used a 2-year strategy. The rituximab can be administered as a single dose every 2 months, a single dose every 3 months, or 4 weekly doses every 6 months. But the total duration is 2 years. There are some studies that are looking at longer durations. There are some studies that are comparing 2 years to 5 years. The data so far suggests that there is a small incremental benefit for the longer duration, but it isn't much and probably isn't worth the 3 extra years of treatment for such a small benefit. And we actually did studies at the University of Wisconsin in mantle cell lymphoma where we tried to give the maintenance for 5 years. I felt like the trade-off wasn't worth it. Patients were on therapy a long time. We started to see problems with infections that I thought was more than we saw with 2 years of maintenance. And then obviously there's an economic issue, and I think we need to be very thoughtful as physicians about whether this additional therapy can really be justified from a cost perspective. Obviously, if the patients derive a big clinical benefit, then it's worth it. But if the benefit is marginal, then I think we should really think very carefully about that.